The leads look at specific parts of the heart. What exactly are they looking at? This is our lecture for today. "12 leads and 2 planes. 12 windows around the same heart. But windows are only useful if you know what they are looking at. And right now, you don't. You know that the leads exist. You know where they sit. You don't know yet which part of the heart each one is watching. That's what this lecture is about. The map. And why it changes everything. Before we map the walls, one thing worth saying out loud. The ECG is largely a left ventricular tool. Almost everything we read, interpret, and diagnose is based on left ventricular activity. And that's not an oversight. The left ventricle is the dominant chamber. It generates the most electrical force. It has the thicker walls. It does most of the work. So naturally, it produces the strongest signal. Strong enough to reach the electrodes on the skin, strong enough to shape every wave you will ever read. The right ventricle is there. It contributes, but its signal is largely overwhelmed by the left ventricle, which is also why the right ventricle is one of the harder things to assess on a standard ECG. Now let's go back to the heart. The heart isn't one undivided mass. It has distinct territories we refer to as walls. And each wall faces a different direction. Each wall has its own blood supply. And each wall has its own set of leads watching it. This matters because when something goes wrong, it usually goes wrong in one wall at a time. A blocked artery, an area of ischemia, it has a location. And the leads watching that location will show it first. The others won't. That's how we localize problems on an ECG. Not by reading one lead, by reading the right group. Each wall has a dedicated group of leads. Find the group and you will find the problem. The first wall we'll be talking about is the inferior wall. The inferior wall is the bottom of the heart, facing downward. The leads watching it from below are the ones pointing in that direction. Lead 2, lead 3, and AVF. The inferior wall is supplied by the right coronary artery, the RCA. And when the RCA is blocked, it's always lead 2, lead 3, and AVF that will tell you first. The second wall we'll be talking about is the lateral wall. The lateral wall is the left side of the heart, facing outward toward the left. The leads watching it are lead 1, AVL, V5, and V6. This wall is supplied by the left circumflex artery, the LCX. So we have 4 leads, all looking to the left, all watching the same wall from slightly different angles. Two of the most important walls are the septal and the anterior walls. The septal wall is the partition between the two ventricles, sitting closest to the right sternal border. V1 and V2 watch the septal wall. The anterior wall, on the other hand, is the front of the left ventricle, facing forward towards the chest wall. V3 and V4 watch the anterior wall. Now, both the septal and the anterior walls are supplied by the same artery, the left anterior descending artery, the LAD. Sometimes it's called the widowmaker, because when it blocks, a large territory goes down at once. Now here's where the map has a problem. The posterior wall. It's located at the back of the heart, facing away from the chest wall. There are no leads directly watching it. None of the 12 leads sit behind the heart, which means the posterior wall is the one part of the heart the standard ECG cannot see directly. And this is not a small problem. A posterior MI, myocardial infarction or heart attack, can be completely missed if you only read what's in front of you. There are ways around this, indirect signs that appear in other leads when the posterior wall is in trouble. But that's a detailed conversation for later. For now, just remember this: the posterior wall exists and no lead directly watches it. That blind spot matters. One more concept briefly. When one wall of the heart is in trouble, the leads watching the opposite wall sometimes show a mirror image. Not because that wall is damaged, because they are looking from the other direction. These are called reciprocal changes. They are a reflection, not a finding in themselves. And they are one of the most useful confirmation tools in ECG reading. We'll come back to this in detail when we reach ischemia. For now, just know they exist. Now let's put it all together. The inferior wall is seen by leads 2, 3, and AVF. The lateral wall is seen by leads 1, AVL, V5, and V6. The septal wall is seen by V1 and V2. The anterior wall is seen by V3 and V4. The posterior wall has no direct leads looking at it. And finally, the AVR is there to make sure the ECG is correctly drawn. This is the map. Keep it. Every ECG you read for the rest of your career will use this map. And now you know the 12 leads. You know the 2 planes. You know which lead watches which wall. The foundation is complete. The next lecture, we are going to talk about the actual ECG lines. That's all. Thank you and see you in the next lecture.